exploring the different issues, viewpoints, and latest research regarding the nutritional needs of ICU patients and its impact on patient outcome was the focus of a Nestlé Nutrition Institute satellite symposium at ESICM 2017.
This symposium was about the role of hyperglycemia, hypoglycemia, glucose variability on patients' outcome, and the role of nutrition, and that is the amount of glucose, protein, and the ratio between the two in the nutrition related to glucose variability and levels of hyper and hypoglycemia, and patients' outcome, mortality, weakness, length of stay in the ICU.
This glycemia can be defined as either severe hyperglycemia or hypoglycemia or high glycemic variability. All these three domains have been associated with poor outcomes in wide ranges of critically ill patients.
Therapeutic approaches are evolving.
Regarding insulin therapy, there was a huge success in the first study, published in 2001, but all the other studies performed and published later didn't confirm this success. This is why we need to find other modalities able to treat or to prevent this glycemia. Indeed, enteral nutrition or continuous enteral nutrition can have a key role just to avoid the variability, just to prevent to some extent hyperglycemia, and also to boost the so-called incretin effect. The incretin effect is the stimulation of endogenous insulin release by enteral nutrition, which is a physiological event. Enteral feeding using slow carbohydrates may prevent to some extent this glycemia, but the effect on the global outcome should be assessed in large-scale studies.
Research is changing clinical practice.
The initial randomized controlled trials showed that hyperglycemia in the context of early parenteral nutrition is harmful, as it increases mortality and several morbidity outcomes. Lowering blood glucose into the healthy fasting range reduced mortality and reduced morbidity. I think since we've shown that early parenteral nutrition is not beneficial for patients, so we're not using early parenteral nutrition anymore, I think the field can only evolve if we redo the randomized controlled trial in the absence of parenteral nutrition in the acute phase of illness. So we start the RCT comparing hyperglycemia without insulin or with as little as possible insulin versus strict blood glucose control to the healthy fasting ranges.
The protein-energy balance is an area of focus.
An alternative way to lower blood glucose could be to reduce the amount of glucose or carbohydrates in the nutrition, in the enteral nutrition, because that's what we're using at this point. And this is really an open field for research.
The challenges of meeting the protein requirements and the protein targets that we have in critically ill patients are really significant. It's hard for us to give the amount of protein that we want to give, especially with the historically formulas that are very high in energy and lower in protein. And these formulas have not really allowed us to give the protein levels that we want without either overfeeding or with supplementing with exogenous protein. The DIVINE study was set up to look at a newer formula that is high in protein and lower in carbohydrates in order to both try and meet the protein requirements in an easier way and to actually decrease the amount of carbohydrates to decrease the incidence of hyperglycemia. And this study has helped us understand glycemic control. The higher protein, lower carbohydrate formula that was used in the intervention arm actually showed a considerable reduction in the blood sugar levels that we saw in our critically ill patients, an actual decrease in the variation in those blood sugar levels, and all of that was done with the use of less insulin, which is a dangerous medicine for our ICU patients because it makes blood sugars harder to keep in the range that we want. We are headed towards individualized patient care, and the DIVINE study suggests to us that different formulas for different patients may be the right thing to do for them in order to both improve their blood sugar control and decrease mortality, decrease length of stay, and even improve long-term outcomes.
The role of protein for ICU patients is strong.
After a catabolic illness and someone's admitted to an ICU with a catabolic or stressful illness, the rate of muscle loss begins very rapidly. We see it really within about 48 hours. We see rapid loss of muscle mass. If that's not corrected, if that's not protected from more catabolic loss, the patient's outcome is dismal. The role of protein in the ICU is crucial. The total energy use is probably not as critical as the protein need. The protein need today seems to be the one thing we have that can support muscle growth, support myocardial function, support pulmonary function in a patient when they need that nutrition. The first 2 or 3 days, maybe we don't know how much to give, but clearly we should be given some protein throughout the ICU stay. It appears that a higher quality protein with a higher ratio of essential amino acids to non-essential amino acids seems to be better. And it looks like the quality of protein we know is critical in the rate at which we can get muscle stimulus to that effect.
The nutritional challenges of ICU patients is a research and innovation frontier.
Research about nutrition in the ICU should focus on when to start high protein enteral nutrition. Is this very early on in the course of critical illness or preferably later? Also, we should try to identify a biomarker that could indicate at which point in time a certain patient is able to use macronutrients, protein, but also lipids or glucose, use those for anabolism.